Our lecture today is about cell and molecular biology, tooth movement. The last lecture we talked about cell and molecular biology, bone metabolism, and today we're going to talk about tooth movement. So the lecture outline today, we're going to talk about theories of tooth movement. We're going to talk about the stages of tooth movement, types of tooth movement, root resorption that happen due to tooth movement, exfoliation of primary dentition, then the eruption of the permanent dentition, and what are the theories of tooth eruption. So why do we study biology of tooth movement? Because simply we need to understand the mechanics that we are used in order for these mechanics to be efficient and least determined or least painful or harmful to the patient. So we need to be very efficient with the amount of the force that we are applying. So we want our force to be efficient and less harmful to the patient. So Prophet came up with the equilibrium theory, which basically stated that the teeth are in a state of equilibrium between the forces from the tongue and the lips, or in these cases the cheeks, the tongue and the cheeks, and the periodontal ligament usually stabilize the teeth. How is that? So if you look at the photo here in the top, the tongue force is slightly more than the force produced by the lips, and then the periodontal ligament will act as a stabilization for these teeth to stay where they are. Now, if a force is applied more than these ones for any reason, the teeth will move. And the orthodontic force, for example, is an extrinsic force that we apply to move the teeth. Extrinsic force can be applied as well from habits. So any force that is applied that is going to change the equilibrium and will result in the tooth movement and change the state of the balance. Now the tooth movement will depend on the size, magnitude, duration, and definitely the direction of the force that we are applying. So how the tooth will move when a force is applied to this one? What are the theories that are trying to explain how the teeth move? The first one is called the pressure tension theory. So basically when you move the teeth, first they tip inside the bone, and then they will compress the bone on one side and they stretch it on the other side. So we call this one here is the compression one, while we call this one the tension side. So here is the compression side, while here is called the tension side. Now, so what's going to happen is that there will be a change in the blood flow within the periodontal ligament. So basically, once you tip the tooth, the blood vessels here in the compression side will be compressed, but they will not be completely occluded. So they will be compressed, but still there will be a blood flow in that capillaries. So in the compression side, which will result in a bone resorption, that's compression and reduction in the blood flow will result in activation of the osteoclast that will result in bone resorption. However, in the opposite side, when we have the tension, that will be result in stretching of the periodontal ligament and stretching of the vessels. That will result in activation of the osteoblast and result in a bone deposition. So changing in the degree of pressure that we apply to the blood vessels in the compression zone and the tension zone will result in different response in bone resorption in this area and bone deposition in this area. But is this theory true? Now, for the four theories that we're going to discuss now, we do believe of these theories, but however, there is certain things that against these theories. So there is no one theory that is 100% correct. So what are the evidence against the pressure tension theory? Now we are assuming that we have a different pressure between the tension side and the compression side. However, the periodontal ligament, as we can see here, is a continuous one. It's a continuous area. And according to the Pascal's law, if you apply a pressure here, it will be distributed according to the whole system. So basically, you can't have a higher pressure area in one side compared to the other side. So that's a major fault in this theory. The other thing is that disruption of the collagen fiber, because we said when we do in the tension side, there will be stretching of the periodontal ligament, mainly the collagen fibers, and that will result in bone deposition. But in the animal studies, they kind of injected material that dissolved the collagen fibers, and the teeth still moved. So basically, it's a multifactorial thing. There is more than one factor involved in the tooth movement. So what is the second theory? The second theory is called the mechanical theory, which also is called as a piezoelectric theory. So this theory believes that when you apply a force, as we know, the bone is resilient. So we will have a little bit of distortion of the bone or bending of the bone. And we know that bone is formed from calcium and phosphorus ions. So this distortion of the bone will result in the production of an electrical current or electrical potential that will act on the cell membranes and will activate them either to do bone resorption or bone deposition. Well, so is that really true? Well, yeah, when we apply a force to there will be a bone bending, but the amount of the bone bending will result in a electrical current that decay rapidly. So it will finish quickly. So we will not have a strong current that lasts for a longer time to promote all this tooth movement. And also, for the tooth to remodel, we need potential to be pulsed, not a continuous one. And we don't have that with piezoelectric theory. And also, if you look at the ions, we have the enamel, which is harder than bone, and it has more ions than bone. But still, we don't have, the enamel structure does not remodel. So this theory can be 100% correct. So the third theory that is trying to explain tooth movement is the mechanochemical theory. So we have a mechanical one and chemical one. So what happens when you apply a force? Yeah, we're going to have an alveolar bone bending. So this bending, at that time, we're going to have two sides of the bone. One is convex and the other one concave, similar to the tension and the compression one. Well, in the convex surface of the bone, we will have bone resorption, while in the concave surface, we're going to have bone formation. But how is that mediated? In the convex surface that we have a bone resorption, stretching of this or compression of this periodontal ligament will result in stimulation of increased intake of the calcium ions into the bone, into the cells. So when you move the calcium into the cells, that means that the calcium is reduced in the blood and the area. So now that will be understood as a signal that the parathyroid hormone that is responsible for mobilizing calcium into the blood vessels by activation of the osteoclast will be released. So when we have more parathyroid hormone, we're going to have more bone resorption at the convex side. And that summarizes what I just mentioned. So that was the mechanochemical theory. Now this is the last theory, which is, I'm not going to say the most acceptable one, let's say the strongest one out of them. They're called the and the most recent one, the mechano-biochemical theory of tooth movement. So what is this theory? When you apply force, we're going to cause distortion of the cell membrane. And here, what we are talking about the extracellular matrix of the bone. So when you apply the force, this deformation of the bone, this bone bending, will activate something we call it the phospholipase enzyme, phospholipase A2, that is present in the membrane of the cells. All right, and in the membrane we have the phospholipid. So the phospholipase will degrade the phospholipid and produce something we call it the arachidonic acid. Now then, the arachidonic acid will be breakdown using the cyclooxygenase pathway or lipooxygenase pathway. In the cyclooxygenase pathway, the result will be prostaglandin and thromboxane. While in the lipooxygenase pathway, we have leukotrienes like serine and the heats as well. So this prostaglandin then will act on the cell membrane of the bone and will trigger the release of what we call it the second messenger inside the cells, and that will it will be given to the cells as a sign of doing either bone resorption, if it's an osteoclast, or bone deposition of osteoblast as the cycling AMB. So as you can see here, this process involves the release on the production of the prostaglandin, which is an inflammatory mediator. It's one that is responsible for pain. And that's why the NSAID, which is the non-steroidal anti-inflammatory drugs, when it works, it blocks this cyclooxygenase 1. So when you're blocking the cyclooxygenase 1, we will not have a prostaglandin. So will that affect the osteoclastic activity? The answer is yes. But then, does that affect the tooth movement? The answer is no, because we have another pathway, which is lipooxygenase, which in the end will not result in the delay of the tooth movement. So for that reason, NSAID, prescription of the NSAID to patient for undergoing orthodontic treatment will, yes, block the prostaglandin, but then we have another pathway that work on the arachidonic acid. For that reason, the bone resorption will continue, and NSAID will not reduce tooth movement. However, if a patient is taking steroids, which is steroids as well is an anti-inflammatory drug, and we know that steroids block the production of the arachidonic acid. So this is the difference. Now, when you block the arachidonic acid, now we don't have a cyclooxygenase pathway nor a lipooxygenase pathway, so we don't have any of these. So yes, then steroids will reduce the rate of tooth movement compared to the steroids. And this summarizes what I mentioned. So if you look at the drugs and their effect on tooth movement, we studied bisphosphonate in the bone metabolism, and we know it will reduce the osteoclastic activity. And yes, bisphosphonate will decrease the tooth movement because simply you're not going to have any osteoclastic activity. It's a strong indication. What about indomethacin, which is basically an inflammatory drug used for arthritis and to block prostaglandin? As we mentioned before, it will block prostaglandin, but it does not have an effect on the tooth movement because simply we have another pathway that will result in the leukotrienes release and the heat release. So we don't have HET release. These are a mediator for the inflammation and the result in bone resorption and tooth movement. So basically, NSAID will not stop the tooth movement or even delay it. While steroid, as we mentioned, it will decrease the tooth movement because simply they block the production of the arachidonic acid, so we don't have the cyclooxygenase or the lipooxygenase pathway. So what are the stages of the tooth movement? We said that the teeth in imbalance, then what's going to happen when we apply the force? So when you apply a force into the tooth, you disturb the balance. Now the teeth are there. They are there because it's balanced between the forces around it from the cheeks and the lips, as we mentioned. Then an extrinsic mechanical force will be applied, either from orthodontics or habit, and that one has to stay for at least 4 to 7 hours to start tooth movement, because this one will lead to a cellular response. For the force to result in a cellular response, it has to be minimum of 4 to 7 hours. For that reason, we can't use force that is lasting for 10 or 15 minutes because that will not result in a tooth movement. It has to be continuous force. But like force that is applied for 10, 15 minutes, an hour will not result in a tooth movement. And that's why when you ask a patient about a habit, if a patient is doing thumb sucking and the duration of the thumb sucking is only 10, 15 minutes, you will see that this will not result in any effect. But if the duration is long, like 7 hours, that will result in an effect. And the intensity, the force that is needed to just start the tooth movement. So if the force reaches the level that can result in a tooth movement with enough duration, it will start a cellular response. All right. In that cellular response, the teeth will start moving according to the theories that we just described. And here we come to something we call it the optimal force. So here you need the amount of the force that is associated with minimal damage to the tooth and maximum rate of tooth movement. So to apply a force, now how much force we need to apply? We know that we have to apply force, right? But what is the magnitude of this force? Very, very light force will not result in a tooth movement because we reach a threshold point that will result in a tooth movement. And then if you apply a too light force, that's the one we are wanted, that will lead to a cell survival. We're going to have a painless tooth movement and the teeth will move. While if you're applying a heavy force, the teeth, we will have a necrosis. And the teeth will move, and we'll see later how, but that will result in something we call it undermining resorption, and we're going to describe it now. So if we apply heavy force or light force, what is the difference? So if you, as you can see here, you apply a force, the teeth will tip, and we have, according to the tension, compression tension theory, we have a compression in this area. So what's going to happen to the blood vessels? The blood vessels will partially be occluded. They will not be completely occluded. They will be partially occluded. Now this partial occlusion of the blood vessels all right, should last for at least 4 hours, up to 6-7 hours, to start a cellular response. And it has to be an enough magnitude. Now, when that happens, partial occlusion of the blood vessels, the cells will understand this as a signal to start doing bone resorption. Now, we know that the cells are responsible for bone resorption are the osteoclast. Osteoclast originated as from the monocyte from the blood vessels. So now these signals will reach to the monocyte in the blood vessels. They will come to the area and they will differentiate into osteoclast, and they will result in a bone resorption from the side of the periodontal ligament and the tooth, from this side. So we call this a frontal bone resorption. So again, for bone resorption to happen or to start this process, we need 4 to 7 hours minimum of application of the force. However, the resorption will not start until 2 days. The cells will be recruited, and then they will be differentiated, and then we'll start the process of resorption. Now, if anything happened, or if any delay happened, that is usually caused by the delay in the differentiation of the monocyte into osteoclast to start the process of resorption. So the tooth will not really start moving until 2 to 3 days, or the bone resorption will not start basically until 2 to 3 days. But when the force is applied immediately after application of the force, because the periodontal ligament is kind of hydrostatic area, it's like a fluid fill, the tooth will be displaced within the socket. So that will cause a pressure on the periodontal ligament, and also the bending of the bone that will result as well in activation of the osteo, and the reduction of the blood flow and activation of the osteoclast. But what happens if the force is heavy? So here is the force is light, here the force is heavy. And as you compare the top one to the bottom one, here the blood vessels are completely occluded. There's no blood vessels now at all. So we know that if the blood supply is reduced or is cut permanently, there's no blood supplies, necrosis will result. So in this area, we're going to have necrosis in the periodontium and in the bone cells. So this necrosis is called aseptic necrosis, because basically it's a sterile necrosis. There's no bacteria involved. And there will be a hyalinization in that area. All this area will be hyalinized. So now we're going to have necrosis. Now, the blood vessel is completely occluded. So no way that, or no place, or no route for the monocyte to come from the blood vessels to this area to resorb this necrotic bone. The blood vessels are occluded. So what's going to happen is that this monocyte has to come from the other side, where the blood vessels are still open. So they come from the other side and they start resorbing the bone from the opposite direction of the tooth. We call this undermining resorption. So what's going to happen when you apply a heavy force, the tooth will displace into the socket and then stop. There will be no movement until the macrophages go into the monocyte, come from the blood vessels from the neighboring area, differentiate in the osteoclast, and then start resorbing the bone from the opposite direction until to reach this area. Then the tooth will jump in a one jump, will move one time, because they resorb all the bone, and then all of a sudden the tooth will move. That's the difference between the heavy force and the light force, and that describes what we just said. So if you're going to put that on the chart, what's going to happen exactly, and what are the stages of the tooth movement? This is the start. Here is the tooth movement. This is the time. And the first stage of the tooth movement, which is the result of displacement of the tooth within the periodontal ligament. So as you can see here, simply was just you apply the force to the tooth, and a huge jump happened, like this one from here to here. At time 0, you apply the force, all of a sudden the tooth moved a huge amount. And that's we call it the first stage of tooth movement. So what's happened here? The tooth is displaced within the socket. Now, the bone is bended now. We have electrical current, according to the piezoelectric theory, that will stimulate tooth movement. Or according to the pressure tension theory, now we have a pressure in certain area that will stimulate a cellular response. Or according to the mechano-biochemical theory, that now the tooth is displaced, the cell membrane is distorted, and we're going to start the process of phospholipase to digest these the phospholipid in the cell membrane to start the process of the tooth movement. Now, if the force that is applied is heavy, now the blood vessels will completely occluded, so no access of the monocyte to the area to differentiate an osteoclast, and we have to wait until the osteoclast from the other opposite side, starting the resorption, which we call it undermining resorption, eat all the bone that is necrotic, and all of a sudden the tooth will jump a sudden jump. So this stage we call it the lag stage, the second stage. Lag means nothing is happening, and as you can see here, the time is passing and the tooth is not moving, and then all of a sudden the tooth will jump because all the bone is resorbed, and that will call the post lag stage. So if you can look here, this is the tooth movement again, this is the time. We apply the force, displacement in the socket, all of a sudden one jump, and then heavy force applied, no movement at all, which we call it the second stage or the lag phase, and then all of a sudden the tooth will jump, we call this the post lag stage. While the light force, the tooth movement will be continuous without lagging period. However, in real life, we wish and we would love to see this. But in real life, what happens is this jumping. The tooth will kind of like have jumps when they do the tooth movement. However, just to mention that whenever we apply force into the tooth, we know that we should apply light force and we have to apply light force. But then we are assuming that the periodontal ligament wall is a completely smooth surface. However, that's not true. It's a rough surface. So when you apply a force, there should be a area that elevation and depression within the periodontal ligament. And when the tooth is displaced, there definitely be an areas in which you will have a contact between the bone and the periodontal ligament. That's a small area, definitely not a big one. But this when you apply a light force. So this displacement will result in necrosis in that area, because that will consider as a heavy force at that area. And that's why we don't do activation more than every 4 weeks. So that's why we see our patients every 4 weeks, because you need sometimes to give time for the tissue to repair. And that's why we do the activation every 4 weeks, not less than that. So compared to light forces, heavy force will always result in hyalinization. We call it septic necrosis. It will result in undermining resorption. It will result in more anchorage loss. And why that? Now, if you remember that we said about the third law of Newton, for each action there is a reaction, opposite in the direction and equal in the magnitude. So if you apply a heavy force, for example, you extracted the two premolars and you want to retract the incisors. So you apply a heavy force. So when you apply this heavy force to retract the incisors, the reactionary force is in the molars to move mesially. So this reactionary force will be a huge amount. It will have an increased amount because you applied already a heavy force on the incisors. So that's why it will result in a more anchorage loss. You are applying a heavy force, and that will result in blocking of the blood vessels, necrosis. That's painful to the patient. And as we mentioned, when you apply a heavier force, we have the undermining resorption. So all of a sudden the tooth will have these jumps, so that we have a little bit of more mobility and more bone resorption, more root resorption as well. Because when you move the tooth and you have a tight contact between the root and the bone, then we have a necrotic bone, and the osteoclast come from the other side, they will start resorbing the bone. And for some reason, then they would not distinguish between bone and roots, and they start resorbing the roots as well. So if you have undermining resorption, you have more risk of root resorption as well. And also, because you're applying the heavy force, you might tip the teeth rather than moving them bodily. And that explains what we just said for your studying, guys. So what are the types of the tooth movement that we have? Now, before we explain the types, we just need to explain this thing, that for each mass, that's a physical thing, there is a center for this mass. We call it center of resistance. If we apply the force directly into the center of resistance, that will result in a movement of this object, all parts of this object, in the same direction with the same speed. In the teeth, the center of resistance is the middle side of the root, or like the middle points of the root, embedded inside the bone. So this is the side of the root embedded inside the bone. This is the middle of this embedded inside the bone. So if I'm going to move the tooth, I have to apply the force into the center of resistance. If I apply the force into the center of resistance, all the parts of the tooth will move in the same direction with the same speed. So the center of resistance for a single rooted teeth is in the middle part of the root embedded inside the bone, while for the multi-rooted teeth, it's at the tri or bifurcation area. So as you can see here, we can't really apply force into the center of resistance because simply we apply force on the crowns of the teeth. So what happens when you apply the force to the crown? We apply it away from the center of resistance, and here is the distance from the point of force application to the center of resistance. If you apply the force away from the center of resistance, that will result in a rotational movement. The tooth will rotate in this direction. We call this direction or rotation moment. And this is the direction of the moment. This is the direction of the rotation. And simply, we can't apply the force to the center of resistance. We have to apply the force away from the center of resistance. Then, how can we achieve bodily movement? Simply, we need to use something we call it couple force. And this is how we use fixed appliance, in which we apply couple force, that two forces equal in the magnitude, opposite in the direction, and that will result in a bodily movement. To make you understand it, simply look to the door. If you push this door with your hand only, so simply you are pushing away from the center of resistance, that will result in the rotational movement. This side of the door will move in this direction, while the opposite side will move in the opposite direction. But what happens if you push the door with your hand and your feet at the same time? That you are applying couple force. At that time, you have a bodily movement that is moving the tooth in the same direction and the same speed. So here we have the types of the tooth movement. The first one is called the tipping movement. We are applying the force away from the center of resistance. Now the crown will move in one direction, while the root will move in the opposite direction. We call this tipping movement. The amount of the force that we need to apply to move the tooth in the tipping movement is between 50 and 75 grams. And we're going to talk more about this force after we finish the type of the tooth movement. And usually the area that is affected with bone remodeling and bone resorption is the crestal part of the alveolar bone. Then we have a bodily movement in which we apply a couple force, and this couple force will result in a whole movement of the structure in the same direction with the same speed. Now, because here you are moving the whole tooth at the same time, we need more force. It's almost double the amount of the force about when we move tooth in the tipping movement. So we need 100 to 150 grams to move this tooth as a bodily movement. The third type is the intrusion, which basically moving the tooth upward inside the socket. So as you can see now, we're moving this tooth in this direction. So basically, you are pressurizing or occluding the main blood vessels going into the tooth. That's why we have to be very careful not to block this blood vessels in order not to result in necrosis of the pulp tissue. For that reason, the least amount of force is always required when we do intrusion, and it's 15 to 25. And the bone remodeling usually happens at the apex of the tooth in this area. So remember, when you do intrusion, to avoid necrosis of the tooth, we need to apply the very light force of 15 to 25 grams. Now, opposite to intrusion is extrusion, which basically you are moving the tooth away from the socket. And here what's happening is that we're going to do tension and stretching of the blood vessels. Usually this would need a force between 50 and 100 grams. Now then we have rotations in which we apply, and when we talk here rotations, we mean spinning around the long axis of the clinical crown. In order to do this, we need a force from this direction and opposite force in the opposite direction to spin the tooth. And here we need a force between 25 grams and 100 grams to move this tooth in a rotation. Then the last one is called the torque movement. And in the torque movement, it's similar to the bodily movement, but what happens is that you control the crown and you mainly move the roots. And here we need more force. It's between 75 and 125. I want you to understand the difference between proclination and torquing. Now, proclination or the tipping movement is basically you have this crown here and you move this crown in this direction. So the crown will move forward while the root will move backward. That's called proclination. And this movement will give you space if you are doing orthodontic treatment, because simply you're doing tipping movement. You are proclining the teeth. You're moving the crown in one direction and the root in the opposite direction. Now torque is different. The start point is here. And then when you do the torque, the anterior-posterior position of the crown is stay where it is. It stay like that. Only the angle of the crown will be changed. So you hold the incisal edge and then you move the root all the way posteriorly. So the angle of the crown will be corrected, but the crown does not really move in the AB position or AB direction. So anterior-posteriorly, the crown will not move. So the overjet will stay the same, but the angle will change. Now this movement is called torque, and this movement requires space. It does not provide you with space. So back again to the definition that we said, optimal force. So what is the amount of the optimal force that we need? We know the definition, that's the minimum amount of damage and the maximum rate of tooth movement. And we have these numbers that they just mentioned. And this one is quoted from Prophet textbook, Contemporary Orthodontics, and that one is used from many animal studies. But are these numbers valid? Do we have now to get a gauge in the clinic and start measuring the amount of the force that we apply? Unfortunately, the answer is not, because we know that we need a light force. But the thing is, in the clinic, it depends on the many factors. First, the size of the tooth, the morphology of the tooth, the amount of the periodontal support of this tooth. And what we know from the evidence, that for a tooth to move, it has to have a minimum amount of force. As you can see here, this is the amount of force applied, and this is the amount of tooth movement on the graph. So it does not start from zero. You need to have certain amount of force, then the tooth will start to move. And what we know from the evidence, that you apply force, as much as it increases, the amount of the force increase, the amount of the tooth movement will increase, until we reach a point. After that, even if you increase the amount of the force that you apply, you will not increase the amount of tooth movement. It will stay steady. But also, if you increase the amount of the force, you're applying heavier and heavier force, the rate of the tooth movement will start to decrease. So you would never want to be at this side of the curve, and you prefer to be at this side of the curve by using a lighter force. However, to quantify it exactly, there's many researchers, and that is the numbers that can help you. But mainly you need to understand that it's multifactorial, depending, again, as you mentioned, the size of the teeth, the morphology of the teeth, the nature of the bone of the patient, the periodontal ligament. So we can't tell exactly how much the amount of the optimal force that we need to apply. So now we finished with the tooth movement. Now, what about the root resorption that happens due to the orthodontic movement? As we know, one of the risk factors of starting orthodontic treatment is root resorption that is associated with orthodontic movement. So the question is, when we move the teeth, the bone will resorb, صح? So here you are moving this tooth, there is a compression area. The root is now causing pressure into the bone, or into the periodontal ligament and then bone. So why the bone will resorb, why the cementum will not resorb? So why the only bone, the one is resorbed? Why not the cementum? First, we have something we call it the anti-angiogenic effect of the cementum, which mainly they block any blood vessels to grow inside the cementum. So in the bone, we have the cortical bone and we have the cancellous bone, and we have bone marrow inside the cancellous bone. So we have blood vessels. So we have cells that are responsible for bone resorption. While in cementum, we can't have blood vessels, can't grow in cementum. For that reason, they are more resistant for resorption compared to the bone. And also, the periodontal ligament are densely inserted into the cementum. That will prevent resorption as well. And also, the cementum is harder than the bone. The minerals in the cementum is more than that in bone, and that will give it more resistance for resorption compared to the bone as well. Now, when the tooth move, sometimes if you apply a heavier force, as we said, now we have an undermining resorption, then the the osteoclast will resorb bone, and sometimes will cause bone resorption, root resorption, sorry. So that's the case where we have root resorption. So when we have a root resorption, that cementum will be repaired by a repaired cementum. Now this repaired cementum is less mineralized compared to the cementum, still more than the bone, but less than the regular cementum, which make it more vulnerable for resorption compared to the regular cementum. For that reason, if a patient attended to clinic who had previously an orthodontic treatment and a previous root resorption, it means that he will be more vulnerable for more resorption because the repaired cementum that he has is less mineralized compared to the cementum, the original one. So root resorption will be covered in details in the iatrogenic effect of orthodontic treatment, but just here quick peek on it. The risk for root resorption, sometimes in family history because it's genetics, general health of the patient. Teeth with taurodontism will have more resorption. Invagination teeth that does like dens invaginatum will have more resorption. History of trauma, if the patient has a history of trauma that resulted in a previous root resorption due to trauma, this patient is at high risk of root resorption. As we said, previous history of root resorption as well for any other reason as an orthodontic treatment before, that will result in more root resorption after orthodontic treatment. And as we call it, petite or pip shaped roots, that is narrower one, that will result in a more root resorption for these ones. So if you have a patient with a root resorption or a higher risk of root resorption, what should you do? We should avoid a lot of torquing because torque is mainly movement of the root inside the bone. So you need to avoid that one or reduce it. You need to reduce the use of the elastics. You need to use a heavier force. Avoid using, you need to use lighter force. Try to avoid heavier force. And try to avoid intrusion, because in intrusion you focusing the amount of the force in one area of the tooth, so that will increase the risk of resorption. And try to reduce the time of changing the wires, as we said earlier, because that will limit time for repair of any resorption that happens. That was about root resorption. Now moving to the next topic, which basically exfoliation of the primary dentition. So usually we know that we have a permanent tooth and then we have a primary teeth. Then the permanent tooth will move out, upward and outside, and it will resorb the primary teeth. So what makes the primary teeth resorb? Now the tooth, when they erupt, they can apply pressure onto the bone surrounding the tooth. This pressure will activate the osteoclast, and this osteoclast will be encouraged or like stimulated to resorb the roots of the primary teeth. However, these osteoclasts will be also activated by the masticatory forces. And as we get older, compared to the children, and moving from being a child into being an adult, the masticatory force will increase. And this increase in the masticatory force will result in increase in the bone bending, in the activation of the osteoclast and bone resorption. For that reason, sometimes, even if you don't have a permanent tooth, the primary tooth will resorb, the root of the primary tooth will resorb, and you're going to see mobility of the primary tooth, because the muscle of mastication, the heavy force applied from the muscle of mastication will stimulate the osteoclast. So if a patient has a missing permanent tooth, that does not mean that the primary tooth will stay forever. Then eruption of the permanent dentition. So now we know that we have the primary tooth that is resorbed, so what's going to happen the next is the eruption of the permanent tooth. So eruption is defined as a physiological and developmental event, and there is a lot of phases associated with this one. The first phase, we call it the pre-eruptive phase. So basically the tooth is here, the tooth is completely formed, the tooth germ, now the enamel organ has formed the tooth, and then the roots start developing and the roots start moving inside the bone out. So this one we call the pre-eruptive phase. The tooth is moving inside the bone. Here, the follicle of the crown play a major role in that one, because as in the studies, what they did is the resorption of the bone that happened in above the tooth happen even if you tie and ligate these roots that they are developing into the bone. So what they did in a study, in animal studies, they have the tooth, it's erupting like this. And what they did is they have a metal ligation, and they ligated this root into the bone. So you imagine if the root is responsible for the bone resorption surrounding the tooth, that because now they kind of tied the tooth, no resorption will happen. But what happened? No bone resorption continued because of the follicle. So the follicle is playing a major role in the pre-eruptive phase, the follicle surrounding the enamel organ of the erupting tooth. So then we have the eruptive phase, which basically after the tooth penetrated the mucosa, and that is the tooth movement until it reaches the functional occlusion. Then we have what we call it the post-eruptive phase, and that one is a compensational one, in which if we have an attrition of the teeth or a tooth that is lost and then we have no opposing, the teeth will understand that as a signal that they have to erupt until they meet. So if you think about it, if you have a patient with a bruxism, so the cusp will be they will have a wearing of the cusps. So then if the teeth does not erupt, then you will have a posterior open bite. But what happened is the teeth will erupt until they meet. We call this the post-eruptive phase. So what stimulates the teeth to erupt? What are the theories of tooth eruption? First, for eruption to take place, you need to know that bone has to be resorbed coronally above the tooth that is erupting. And also, bone has to be formed apically underneath this tooth. So because it's moving in this direction, bone has to be resorbed here and deposited here. And also, the periodontal ligament that is surrounding this tooth has to be remodeled to accommodate this amount of tooth movement. And the last thing, that the epithelium, that the gingival margin and all that, it has to go with this amount with the eruption. So what is the theories of tooth eruption? The most kind of accepted theory, or the strongest theory, is the role of the dental follicle. And as we said before, that if you have a dental follicle and you tie the root into the bone, and then still the bone will resorb above the follicle. So if you look at this tooth here, you can see this is the follicle. It's the part that is surrounding the enamel organ, we call this one, or the enamel of the tooth. So it plays really a role in regulating bone activity associated with bone resorption. And removal of the follicle has resulted in cessation of the eruption. So that means it's very important in the process of tooth eruption. So what do we believe now? That the follicle play a major role in the eruption of the tooth when it's in the intraosseous phase, when it's inside the bone. But when the tooth erupts and it becomes supraosseous, then it plays less role, because now we don't have a follicle, we don't have resorption. So mainly follicles play a role in the intraosseous part, where you have to have a bone resorption of the bone surrounding the permanent tooth. And in an experiment, what they did is they have a follicle, they remove the tooth inside that follicle, and they place a metal component like this one. And what they noticed, that because the follicle is still there, this metal component has moved up until it erupted. So that tells you that the follicle is the one responsible for that eruption, because now nothing left but this metal part. And also, if you remove the follicle, the tooth will not erupt. So the follicle theory is the strongest theory. However, we still have another theory, that the periodontal ligament. So the periodontal ligament is surrounding the tooth, and the theory is that this pressure from the root elongation and the periodontal ligament will result in the tooth eruption. However, even teeth with disrupted, they did an experimental study in which they caused disruption of the periodontal ligament, and the teeth still erupt. However, if you have an ankylosis, a tooth is ankylosed, it will not move. So you think, okay, does periodontal ligament then play a role? Because if there's no periodontal ligament, then there's no tooth movement. But with eruption, I think it's slightly different, because even if you destroy the periodontal ligament in the experimental study, still the teeth erupt. Bone remodeling. Now we have this theory come into more focus because of something we call it the gubernacular canals, and this is it. When the tooth erupts, we'll have resorption of the bone as a canals like this one, and this one happen irrespective of the tooth eruption. So even if the tooth is not erupted, fail to erupt, this canal will develop. So that gives us to the conclusion that genetics play a major role in this one. So because of that, because that genetics is playing a major role, the study is now focusing on identifying the genes, and these are the one that they came up as a responsible one for the eruption of these teeth, and that's kind of as well acceptable theory after the follicle theory. And that is even proven more that in condition like that affecting bone remodeling, sorry, like the cleidocranial dysplasia, they will have a delay in the tooth eruption. So the genetic theory that involved in the tooth eruption is not the strongest theory, but it's a strong theory, and it's proved that the patient with problem with bone metabolism like cleidocranial dysplasia will have a delay in the tooth eruption. Now, other forces, like for example root elongation and the static pressure from the periodontal ligament, does that result in eruption? However, it's been shown that even rootless teeth without roots, they still can erupt. So basically, that tells you that root elongation is a cause of eruption, but it's not the primary cause of the tooth eruption. And also, the hydrostatic pressure within the pulp tissue and the periapical area, it's been advocated as a cause for the eruption. But again, necrotic tooth or non-vital teeth erupted normally. So that does tell you that, again, could be a factor, but it's not the main factor for the eruption. And thank you very much for listening.